My name is Stephen Cohen. I'm the Edmund I. Eager Endowed Chair of Anesthesiology at Northwestern and a professor of anesthesiology, neurology, physical medicine and rehabilitation, psychiatry, and neurological surgery at Northwestern University Feinberg School of Medicine, and a professor at Walter Reed National Military Medical Center, where I also direct pain research. This talk is on nociplastic pain. So at the end of this talk, the audience should be able to identify patients and conditions associated with nociplastic pain, be familiar with mechanisms underlying nociplastic conditions and why it's important for identifying it, understand the effect nociplastic pain has on pain treatment outcomes, and improve decision-making when faced with individuals with nociplastic pain or suspected central sensitization. These are my financial disclosures. So it's long been recognized that there are different types of pain. Nociceptive pain is pain that results from activity in neural pathways secondary to actual or potential tissue damaging stimuli. It's the most common form of chronic pain. It encompasses arthritis, most types of spinal pain. But it's long been recognized that there's another kind of pain called neuropathic pain. Although John Fothergill is often credited with, inventing this concept in 1773, the term originated way before that, over 1,000 years ago, with Persian scholars. You can see the description from Haley Abbas describing nerve pain as like ants or bugs moving, like penetrating needles in your internal organs, with deficits in sensation and motor dysfunction, similar to what happens when your foot falls asleep because you sit on it. The main difference between neuropathic pain and nociceptive pain is the absence of transduction. So with neuropathic pain, nerves are stimulated directly, and it's associated with a poorer prognosis. So the likelihood of being left with persistent pain is much higher after nerve injury. And in probably the best studies, they consider between 15 and maybe 30% of chronic pain to be primarily neuropathic. But it's been long recognized that not all pain falls into one of these categories neatly. So in 2016, the term nociplastic pain was proposed as a mechanistic descriptor for chronic pain states that are not characterized by obvious activation of nociceptors or neuropathy, but in whom clinical and psychophysical findings suggest there's altered nociceptive function. So it's defined as pain that arises from altered nociception, despite no clear evidence of actual or threatened tissue injury. So there's some things that characterize nociplastic pain. So it has a very strong female prevalence, higher than the female prevalence for other pain conditions. There's no biomarkers, so it's challenging to diagnose. These are syndromes, so they're constellation of signs and symptoms. So treatment is often symptom or condition-based rather than mechanism-based, and we know that mechanism-based therapies generally respond better. If somebody has an autoimmune condition that's causing chronic pain or other symptoms, you can give drugs that suppress the immune system. If somebody has pneumonia, you would use an antibiotic to treat it. Central sensitization is very prominent in at least 20% of chronic pain conditions. So it's not binary, it's a continuum. And it can be diffuse or regional, and regional is more common than diffuse pain. There are no separate pathways for different categories of pain, but it's still important that we categorize them. As I mentioned, different types of pain are often viewed as different points on a continuum, and there's significant overlap. So large-scale studies done in primary care and orthopedic populations have found that more than 50% of people have mixed pain phenotype. Categorization is important for diagnosis, for doing research, and to get authorization to do procedures or even to try medication. So categorization affects decisions at all levels of pain. Should one order an MRI in somebody with back pain? Should you use NSAIDs or muscle relaxants to treat pain, or should you consider adjuvant therapy? So, as I mentioned, mechanistic-based treatment of pain is widely acknowledged to be better than disease or symptom-based, but in practice, it's hard to determine mechanisms. So for nociplastic pain, we can do things like quantitative sensory testing, where we can see, that there is deficits in conditioned pain modulation, formerly known as descending noxious inhibitory control. We can use IV confusion tests. We can do inventories, questionnaires like central sensitization inventory. There's many conditions that contain very prominent nociplastic qualities. You have very common ones like fibromyalgia, irritable bowel syndrome, but there's lots of others that fall somewhere along the continuum. So non-specific back and neck pain, burning mouth syndrome, temporomandibular disorder, thoracic outlet syndrome, atypical facial pain, post-infectious chronic pain conditions, including post-COVID, migraine headaches. So these slides are busy, and I'm going to go over how to distinguish some of these. So for neuropathic pain, the physician designation is always considered the gold standard, but there are validated instruments to help people, particularly non-pain physicians, come up with them. Things like Pain Detect or SS-LONS. These were developed before nociplastic pain became a type of category. Because there's nerve injury, we can use electrodiagnostic testing like EMG. For people with small fibrineuropathy, we can use skin biopsies looking at difference in the density of small nerve fibers in the epidermis, MR neurography, selective nerve root blocks. For nociceptive pain, because it involves tissue injury, you can see this, whether it's on radiological imaging like MRI or even directly through endoscopy, cystoscopy. But we also have instruments for nociplastic pain, things like the Pain Sensitivity Questionnaire, Fibromyalgia Impact Questionnaire, Central Sensitization Inventory, which is probably more specific, but again, there are no biomarkers. Quantitative sensory testing, including conditioned pain modulation, could be helpful. You could see things like temporal summation. Etiology, right? This is defined by the International Association for the Study of Pain. Neuropathic pain is disease or injury affecting the peripheral nervous system, and it can involve the central nervous system, like central post-stroke pain. For nociceptive pain, you have, actual or potential tissue injury or something that's perceived as such that affects muscles, joints, tendons, and they can also affect viscera. Visceral pain is a little bit different. There's a lower density of nociceptors, so you can get convergence in the spinal cord. It often responds to stimuli like stretching of capsules or ischemia rather than cutting. With nociplastic pain, you have maladaptive changes that affect nociceptive processing. So you can have amplification of pain signals. You can have decreases in descending modulation. There's alterations in gut microbiome, dysfunction of the endogenous opioid receptors. The onset of neuropathic pain can be acute, like stroke, spinal cord injury, or it can be, insidious, like developing diabetic neuropathy, metabolic processes. Same thing for nociceptive pain, right? You can have trauma, you can have infectious processes, which are acute, kidney stones, heart attack, or it can be insidious, like arthritis. Same thing with nociplastic pain. Usually it's insidious. Central sensitization doesn't occur overnight, but it can also be acute. And most commonly it occurs after like an illness or some kind of physical or more commonly psychological trauma. Neuropathic pain is often described in terms of like lancinating, shooting, tingling, prickling, electrical like stabbing, whereas nociceptive pain is deeper, throbbing, aching, often described as pressure-like. Nociplastic pain is most similar to neuropathic pain in terms of the descriptors. Sensory deficits are common with neuropathic pain. They're not universal. With central pain, they're very common. When deafferentation pain occurs, pain happens in the distribution of numbness, like after a stroke or a spinal cord injury, or with limb amputation. With nociceptive pain, sensory deficits are not frequent. When they happen, they're non-dermatomal or in a non-nerve distribution. Sensory deficits are quite common with nociplastic pain, but they're non-dermatomal. Motor deficits, common after neuropathic pain. Motor fibers are larger. They might be more resistant, as anesthesiologists in the audience know, right? You get a motor block after you get a sensory block or a blockade of pain fibers, and you get recovery first. With central pain, motor deficits are very common. And like I say, they tend to occur along, tracks. Dystonia or spasticity can be common. People with nociceptive pain also have weakness, but it's usually pain-induced, not neurological. With nociplastic pain, generalized fatigue or weakness can be very, very common, and it can be secondary to deconditioning. Hypersensitivity, common in neuropathic pain. It can be evoked with non-painful stimuli when it's known as allodynia, or after painful stimuli where you have an exaggerated response, including secondary hyperalgesia. As I mentioned, allodynia and numbness may coexist, like in deafferentation pain. Hypersensitivity is not common in chronic nociceptive pain, although with acute injury, you can get it. Like if you skin your knee, when you wash it out with water, it's painful. People with visceral pain can also exhibit somatic hypersensitivity and vice versa. With nociplastic pain, hypersensitivity is extremely common. This is a hallmark. It can be diffuse, more common it's localized. And sensitivity to mechanical stressors are more common though than allodynia. Pain pattern with neuropathic pain, distal radiation is common. It's in the distribution of a nerve or a nerve root. With central pain, it can occur like in half the body after a spinal cord injury, or on one side after a stroke. Radiation occurs with nociceptive pain, but it's less likely to be distal. There's more variability. Proximal radiation is common around the area of the anatomical structure, and radiation tends to be more distal the greater the magnitude of stimulus. With nociplastic pain, you have just these diffuse pain patterns. They don't follow anatomical referral patterns. People can exhibit symptoms outside of typical patterns even when they have neuropathic pain. So someone with arthritis can have pain from the mid or lower calf to the thigh. With neuropathic pain, exacerbations are common. They're more unpredictable. That's why people with neuropathy tend to experience worse symptoms at night. With nociceptive pain, they're common, but they're associated with activities that stress the structure. So it could be walking, making knee arthritis worse, or food intake worsening, cholecystitis, going to the bathroom, making interstitial cystitis worse. Exacerbations are very, very common with nociplastic pain. They're often related to psychosocial stress. Autonomic signs, they happen with neuropathic pain. These can include color changes, temperature changes, pseudomotor changes. We see them often in CRPS type 1 and type 2. CRPS type 1 is probably considered more in nociplastic pain. They're not common in nociceptive pain, and they're very common in nociplastic pain. in like postural orthostatic tachycardia syndrome, clinics or POTS clinics. Diffuse pain is extremely common. Accompanying psychiatric symptoms are common with chronic pain in general. For neuropathic pain, it's hard to measure, but there seems to be greater quality of life decrements and psychological stress than after comparable injuries to nociceptive pathways. But for nociplastic pain, they're extremely common. These people get all sorts of symptoms that I'll go over. And like I say, there's higher levels of psychological stress and other symptoms than in patients that don't have a nociplastic component. This is an interesting slide, and there's a few points to be made. So as you can see here, when you look at classic, mostly nociceptive conditions like shoulder pain, hip arthritis, knee arthritis, axial back pain, you can see that probably at least 15% and sometimes more than 30% of people have nociplastic components. But the other thing that you can see here is these are measured with instruments such as, Pain Detect, DN4, S-LONS. And these conditions were developed right before nociplastic pain became a formal entity. So the questions that correspond to neuropathic pain, does it feel tingling? Do you have deficits in sensation? In the absence of nerve injury, you can't by definition have neuropathic pain. So these people that score high actually have nociplastic pain in the absence of nerve injury. But the other thing that you can see here is we need more education, because a lot of these articles, they don't even distinguish. They say people with knee arthritis or hip arthritis, they have neuropathic components. They don't have neuropathic pain, they have nociplastic pain. This is a slide that shows, the one to the far left is from our article in Lancet in 2021. The one in the middle is on neuropathic pain in our review article in BMJ in 2014. And the other one is from David Julius and Alan Bassbaum, published in Nature in 2001. And the important thing to glean from this slide is that there are no separate neurotransmitters or neuropeptides or spinal pathways that distinguish nociplastic from neuropathic from nociceptive pain. So there's an overlap in mechanisms and there's an overlap in presentation. Who gets nociplastic pain? Like I say, the female to male ratio is even higher for nociplastic conditions than it is for non-nociplastic chronic pain conditions. They tend to be people in middle age. They have first-degree relatives with another nociplastic condition. So there could be a genetic predisposition, but also this could be environment and culture. They have more intense pain than one would expect based on imaging. They often have multiple pain conditions. There's a lot of psychosocial pathology, often happening early in life. They have sleep abnormalities. They tend to be overweight. There's a lot of non-pain conditions that are associated with nociplastic pain. These include, low energy, they're easily fatigued, they have skin problems, so they have dry skin, it itches, they get rashes, they go to the bathroom frequently, they urinate, they have bladder problems. Multiple chemical sensitivity syndrome is associated with nociplastic pain. And you can see the journal cover here. We did a study looking at the correlation between hypersensitivity reactions and epidural steroid injection response. The reason being, not everybody with hypersensitivity reactions are associated with nociplastic pain. The other condition they're associated with is somatization or somatoform disorders. So these people notice things, they get reported as having, allergic reactions. So not everybody with somatization or central sensitization has a diagnosis of somatoform disorder or nociplastic pain, but allergies get reported all the time. And we found a pretty strong relationship between having more hypersensitivity reactions, particularly non-immunologic ones, and poor outcomes. They have sleep problems. This includes problems falling asleep, waking up in the middle of the night, waking up early before they're ready to wake up. They're restless. They feel unrefreshed after sleep. They have autonomic dysfunction. This includes like postural orthostatic tachycardia syndrome, poor heart rate variability. They're sensitive not only to pain, but also to lights, to sounds, to smells. Their symptoms worsen with stress, more than other conditions. They have muscle stiffness. They have problems with cognition and memory. With fibromyalgia, this is called fibrofog, and they have hypermobility. So these next couple of slides look at the co-prevalence of psychiatric conditions in common nociplastic conditions. So for fibromyalgia, the current prevalence for depression and major depressive disorder, is 43% and 32%, respectively. The lifetime prevalence is even higher than that, more than 50%. You have high prevalence rates for anxiety and general anxiety disorder, much higher rates of PTSD, and they have other nociplastic conditions. This looks at the prevalence of psychiatric conditions for other common nociplastic conditions. And what you can see here is these include Axis 1 diagnoses like mood disorders, anxiety conditions, but also things like somatization, personality disorders, substance abuse disorders. People with nociplastic pain often report an inciting event. So with fibromyalgia, it's probably at least 20%. Often this occurs subsequent to like an infection, psychological or physical trauma like surgery or motor vehicle collision. With the irritable bowel syndrome, it also often follows gastroenteritis, more common with IBS diarrhea subtype. And there's increased psychological stress scores just before progression from being IBS negative to IBS positive. And a lot of people have major life events within 6 months of a diagnosis of irritable bowel syndrome. Migraine, headaches after TBI. With bladder pain syndrome, it's very similar to IBS. People often have evidence of an infection at onset, but after the infection is eradicated, symptoms persist. With temporomandibular disorder, there is not a great correlation between imaging and pain, but a lot of people have muscle or joint pathology, often that precedes more diffuse symptoms. But often, as we have shown, there's no mechanistic basis between reporting an inciting event and symptoms. People with nociplastic pain don't do well with procedures. So a study about 10 years ago with Chad Brummett, and you can see the graph here, shows that patients who are getting medial branch blocks to diagnose facet joint pain have aberrant responses. And later, the same group found that they had less benefit with radiofrequency ablation. We found that fibromyalgia was not statistically associated with low back pain procedural outcomes, i.e. after epidural steroids, sacroiliac joint injections, or facet interventions. But if you had abdominal pelvic pain, you were less likely to have a positive outcome. Ablin reported significant reductions of somatic symptom scores and widespread pain index after spine surgery. So people with fibromyalgia had less reductions than people who didn't have fibromyalgia. Viken found that, fibromyalgia patients were less satisfied after knee arthroplasty, and other groups have found, including in very large patients, that people with, fibromyalgia, they're more likely to have complications after joint replacement, and they're less likely to be satisfied. In a systematic review evaluating the effect of nervous system sensitization on peripheral musculoskeletal pain treatment outcomes, they evaluated 13 studies. Most involved surgery, most also involved the knee. In 5 exploratory studies, they found an association between quantitative sensory testing, sensitization, and poor outcomes. The two studies that use self-reported measures of central sensitization also reported strong associations. Among 7 large studies that were at low risk of bias, 4 found no association, 3 found an association. So the author has said that there's not sufficient evidence to support an independent predictive relationship between quantitative sensory testing, measures of nervous system sensitization, and treatment outcomes. I would qualify this by saying, one, I don't agree with this. I think that this shows that there is definitely strong evidence. And two, there's also a lot of intersectionality between central sensitization and all sorts of other predictors, including psychopathology, non-organic signs, being overweight. So it's hard to separate out which factor is most responsible. So hence, these do predict poor outcomes. It's hard to say that they're independent. Why do people get nociplastic pain? Well, you have, supraspinal, spinal, or CNS mechanisms. So there's hyperactivity and increased connectivity in parts of the brain and spinal cord that are involved in brain processing. And there's decreased activity in inhibitory areas. We see changes in the size and shape of both gray and white matter involved in pain processing. There is reorganization. They have increased cerebrospinal fluid levels of substance P and glutamate, excitatory neurotransmitters, and decreased GABAergic transmission, which is the primary inhibitory neurotransmitter. These people have glial cell activation. They have problems with endogenous opioid system dysfunction. In some earlier studies, found that they have actually high levels of endogenous opioids. There's probably increased convergence in the spinal cord and clustering from disparate areas. There's also pathology involving local muscles, including pH, fiber composition. They have elevated inflammatory cytokine and chemokine concentrations peripherally, and there's alterations in gut microbiome. How can you identify nociplastic pain? Conditioned pain modulation is a form of quantitative sensory testing. So you can measure pain thresholds and pain tolerance in people. Then you can subject these people to a painful stimulus, like putting their hand in cold water or applying pressure to their calf or their ear. And when people start to naturally inhibit these signals, when you apply the same original stimulus, you'll find that people inhibit those nociceptive signals. So they have higher pain thresholds and higher tolerance. But with people with nociplastic pain, this is impaired, this process. On quantitative sensory testing, you can find temporal summation. So when you apply repeated stimuli, let's say like a pinprick, most people will habituate and it will decrease. People with nociplastic pain, it becomes amplified. There's lots of instruments, as I mentioned, central sensitization inventory, sensitivity questionnaire, fibromyalgia impact questionnaire. Probably the central sensitization inventory is the most specific. But again, with these questionnaires, physician designation is the gold standard. Why do people with nociplastic pain fail treatment? Well, local pathology is very common in asymptomatic individuals. You see this with like knee arthritis, hip arthritis, spine pathology, and it may not be the underlying cause. There's just a poor correlation between imaging pathology and pain. These people often have sleep dysfunction. They have high incidence of psychopathology. So there's a strong affective component to pain that's not going to respond to surgical excision or injections. As the group from Michigan showed, it's hard to diagnose these people, right? They have aberrant responses to diagnostic injections. They have high incidence of non-organic signs, and because they have, impaired endogenous opioid systems, they don't respond to opioids. So if you don't respond to opioids, you have more pain after surgery or trauma, and that by itself is an independent risk factor for persistent pain. payers realize this. And so, universally, whether you're getting epidural steroid injections, sacroiliac joint injections, facet, if you have diffuse pain, they're not going to pay for it because these people don't do as well. These are some systematic reviews looking at the placebo response rate in nociplastic pain. In a systematic review published in 2017, evaluating 124 studies, Chen found an effect size of 0.53, so moderate for fibromyalgia, and the effect size increased with the increasing strength of the active treatment, increasing age, and a higher severity score, but it decreased in randomized controlled trials with more women and who had longer duration of fibromyalgia. Porporati did a meta-analysis looking at the placebo effect in people with temporomandibular disorder and found that it ranged from 33 for ozone therapy to over 45 for laser acupuncture. And Macedo did a meta-analysis in 77 studies containing over 30,000 patients, found that 29% improved versus 58%, or twice as many with active treatment, but 9% were completely pain-free in acute migraine. So what you're seeing here is that the placebo effect is strong, but the treatment effect is much less. So these are not great people to enroll in clinical efficacy studies. So to summarize, nociplastic pain can occur independently or accompanying existing pain disorders. It can be widespread or regional. Regional is more common. There are no biomarkers, so diagnosis is clinical, and there's often some subjectivity there. Nociplastic pain shares many clinical and mechanistic characteristics of neuropathic pain. Not surprisingly, treatments often overlap, i.e. with membrane stabilizers or antidepressants. Patients with nociplastic pain are less likely to respond to regional interventions and opioid therapy. Although there are risk factors for nociplastic pain, it can occur in anyone, and some patients report an inciting event. And the optimal treatment of nociplastic pain requires a multidisciplinary approach that targets all these concomitant pathologies, including sleep disorder, disability, psychological dysfunction. Thank you.